age, they become more of what they previously were. Their ideas get fixed and firm. They have stronger likes and dislikes. They have a view of their own and possibly look with the more younger people with a bit of disdain. And this generally originates from the fact that people are not culturally sensitive. A physician, whatever age, when taking care of the elderly, must be mindful of the cultural practices of the population from which the person is derived from. For instance, if there was a senior gentleman, how would we address him? हिंदी में कहेंगे बाबूजी कैसे हैं आप? It kind of works across religions and faiths. It's a good way to call. If you happen to call them, if there was a lady, you would say Maji. If she's senior, you would call her. This would represent both respect and cultural sensitivity in context of what we see and hear around us, how we address. However, if you were to say कि वो वही जमाल बैठे हैं, उनको जरा देख लिया जाए, सुनेंगे वो अगर, वो क्या सोचेंगे? वो कहेंगे इनको तमीज ही नहीं है बात करने की, ये कहाँ है जंगली जाहिल लोग. That's what he will think. He'll start off with a negativity. The person immediately sort of withdraws. When you try to talk to them, counsel them, talk about them, immediately there is a sort of a mental block. If you feel offended, you need the second thing that we as all sorts of care providers must know is that their physiological functioning as well as their cognitive ability as well as the sense of hearing particularly is often impaired. We may not realize it. So you've called the person once. He may be a bit hard of hearing, he may be a bit distracted. And then you say, सुनाई नहीं दे रहा आपको? इधर आइए बुला रहे हैं आपको. We fail to realize all these are negatives. They completely demolish the relationship between the care provider and the care receiver. It requires a certain amount of consciousness amongst us as care providers in our various roles to be cognizant that besides the cultural gap, there are other things and other barriers. Don't underestimate their sensitivity. If anything, they are more tolerant. ये तो चलता है. This is the way life is. They become cynical. But it doesn't diminish the hurt. Of something that was done. Addressing people is very important. The second is their dignity. Always, and this is general, this is not just for elderly, but we often forget that the elderly also have dignity. You don't disrobe people in a bed and say, chadi kholo, ye kholo, wo kholo. Maybe with women, you may be slightly more conscious, but even for men, it's a good idea to have curtains. It's a good idea to have privacy. This is true for everybody, not just for geriatric people, but in the hurly-burly of daily practice in our wards. We come in, we breeze in with a lot of self-importance. Everybody feels very important and doing something hugely important. But if the interaction, if these, if these courtesies are not taken into account, such as, privacy, addressing with respect, listening more than talking. When you talk, doctors are known to interrupt patients within the first 15 seconds of their conversation. The elderly persons, you may have noticed They're speaking slowly and they're trying to explain a point slowly. You interrupt them and they get irritated. अरे आप मेरी बात तो सुनिए. I don't know, मेरी बात तो सुनिए डॉक्टर साहब. This is how they talk. Their, their cognition is intact, but the response is dampened. It doesn't mean that they are dumb. Please, if you want to be effective, it's only a matter of time before we transit to that phase and we are receiving. I hope it is not too late, that we feel that we didn't do the right things. What's wrong with this doctor here? He's going to behave exactly like you are, cocky, smart, arrogant. Everything is in my hands. The world is spinning on my fingers. That kind of subtle arrogance that comes, well, because society holds healthcare workers in great esteem. So they pump you, but always be mindful of these things. Uh, so small things. The other thing is falls, but this is more medical. However, uh, an extra consideration for somebody who's elderly, especially when moving them around, would be a great help. It'll be a great boost. If you are, again, this is about interaction only. How you hold them, how you touch them, how you look at them, and most of all, you must hear them. So uh, these are random thoughts. Uh, I guess we could carry on endlessly, but it's best demonstrated in the ward, and it's best done on a daily basis and practiced. Consciously practiced. Thank you very much.
I request the dignitaries to kindly disembark from the dais and have their positions in auditorium. Thank you, sir. Thank you, ma'am. Falls are one of the leading cause of injury and loss of independence among the elderly, making prevention a crucial aspect of geriatric care. With this, we start our today's scientific session on fall prevention in elderly. So I would like to invite our chairpersons, Professor Aditya Kapoor sir, Head of Cardiology, SGPGIMS, Dr. Tanmoy Ghatak sir, Additional Professor, Department of Emergency Medicine, SGPGIMS, Dr. Narayan Prasad sir, Professor and Head, Department of Nephrology, SGPGIMS, Dr. Ajit Kumar sir, Dermatologist, General Hospital, SGPGIMS, Dr. Ritu Karoli ma'am, Professor General Medicine, RMLIMS, Lucknow. To introduce our speakers and guest of our honor, Professor A.K. Singh sir.
ऊपर पर लास्ट में हम जा
ऐसे जाएगा फिर हम कितने आपका फॉल्स पोजीशन this one well, full screen okay. Full screen yeah. नहीं आ रहा तो डालना चाहिए सर अच्छा पर है नहीं रहे नहीं निकलते हैं
So, good afternoon. The honor and privilege to introduce Professor Kisling. He is a senior medicinal consultant and has an interest in geriatrics. So, I think his achievements are listed here. I don't need to go through them, and it's an honor and privilege that sir is here. टॉपिक बड़ा इम्पोर्टेंट है फॉल्स एंड एल्डरली सो एज वी समटाइम्स से कि जो फॉल्स हैं एल्डरली की they are just not an event, they perhaps mark the beginning of the end of independence. So we really need to consider this topic in great depth, and who better person than sir to be here and teach us about it, because fall in elderly will encompass various specialties. It's a very important red flag. Cardiac causes हो सकते हैं, metabolic causes, skeletal causes, neurogenic causes. And as Dr. Shaleen sir also said, we need to treat these patients with not only dignity, respect, compassion, because one fall, we might treat the fracture, we might treat the arrhythmia or the pacemaker, but it would spiral the patient into downward thing wherein he'll go down until and unless you treat the root cause. So thank you, sir, for being here, and we'll all be here. Thank you so much.
Thank you, chairpersons, for your kind words. At the outset, I am obliged to Dr. Prerna Kapoor, who has organized this program, and SGPGI family for arranging this program on the geriatrics. My topic is preventing falls in elderly, saving life and independence. Falls are very common in older persons. One fall every year. It occurs in 1/3 of the elderly, and its incidence increases with the increasing age. The maximum incidence, it occurs in among 80 to 84 years. Why not in 85 plus? Because after 85, the movement it becomes hampered. The postural control, it is a skill which develops in the childhood, remains at age till the 60 years of the age, and it declines thereafter. This decline in postural control, it is responsible for the increased incidence of falls in the elderly. Some level of unconsciousness is present in every patient, every elderly person. In the beginning, it occurs only in the difficult situations, but later on, day-to-day activities, they become disturbed. In any situation, fall may occur if the sensory information is inadequate, or the execution of the automatic writing reflex is inadequate, or both are inadequate. This is just how the person falls. The definition. Fall is an unintentional change in position when a person comes to rest on the ground or another lower level freely under the influence of the gravity. Here the influence of the gravity is most important. Not by someone's push and he fall. No, that is not fall. He should fall with the influence of the gravity only. The recurrent falls, if there are 2 or more fall events, they occur within a period of 6 months, and clustering, if the several fall events occur within a short period of time, it always carries a poor prognosis. Implications. It threatens the independence of the elderly. It is responsible for more than 80% of hip fractures in elderly people. Elderly persons are more susceptible to fall-related injuries, which result in disability, chronic pain, loss of independence, reduced quality of life, or even death. The post-fall anxiety syndrome or fear of falling. It is the condition in which an elderly refuses to move or walk for just fear of the future fall or injury, even after having a normal neurological status. It occurs in 20 to 40% of elderly after a fall. There are certain age-related changes which occurs in most of the elderly, rather every elderly. Visual system, there is decline in the visual acuity, contrast sensitivity, depth perception, and dark adaptations with increase in the glare sensitivity. In vestibular, there is loss of labyrinthine hair cells and nerve fibers with reduced vestibulocochlear reflex gain. In nervous system, there is decrease in the neuronal cell density of the cerebral cortex, decrease in the Purkinje fiber in the cerebellum, with depletion of the neurotransmitter like dopamine in basal ganglia. Changes in the musculoskeletal systems. There is decrease in the lean muscle mass and increase in the fat deposition in the tissue, which causes functional decline and debility. There is much more increased contraction of the antagonistic muscles, which causes delayed onset of the muscle activation and increases risk of the falling. There is also reduced muscular strength in legs and ankles with increasing age. Fall is a symptom. It is not a disease. It is always multifactorial in etiology. It occurs due to the accumulation of the multiple chronic disabilities, but it is highly preventable. The diminished alertness, poor concentration, general fatigue, drug-induced sedation, and reduced personal judgment, they all increase the risk of falling. A complex interaction among intrinsic, extrinsic, and situational factors occur in fall. What are the intrinsic factors? They are the age-related decline in functions, which just we have enumerated. But they themselves, they do not cause fall. But what they do, they blunt the correcting reflexes. And disorders contributing to the risk of falling, like disturbance in BP, which may occur in anemia, arrhythmia, valvular heart disease, COPD, dehydration, in all these conditions. Disturbance in central processing, as in delirium and dementia. Disturbance in the gait, like in arthritis, foot deformities, muscle weakness. Disturbance in the postural and neuromotor functions, as in cerebellar degeneration, myelopathy, Parkinson's disease, peripheral neuropathy, stroke, vertebrovascular insufficiency. Disturbance in the proprioception, as in peripheral neuropathy, diabetes mellitus, vitamin B12 deficiency. Disturbance in vision, cataract, glaucoma, macular degeneration. Disturbances in otolaryngologic functions like acute labyrinthitis, BPPV, hearing loss, Meniere's disease. And there are medications which contribute risk of the falling. So in elderly, what we should do? We should avoid these medications like antidepressant, tricyclic antidepressant, and selective serotonin reuptake inhibitors, antihypertensives, antipsychotics, typical and atypical both, benzodiazepines, shorthand long-acting, cholesterol inhibitors, diuretics, NSAIDs, sedative, and hypnotics. These are the intrinsic factors. Extrinsic factors, these are the factors lying outside of the body. They are not in the body, like environmental hazards. They are also very important. As ground surface, if it is uneven, there are loose rugs and mats, so they increase the risk of falling. If lighting, it is poor, dim light in the night. There are low-lying furnitures and footwear. It is also very important. Ill-fitting shoes, they very frequently cause fall. And third is the situational factors. These are situations which increases the risk of falling. Like the commonest is rushing to the washroom, especially at night, in dim light, and the person is sleeping. It is the commonest cause of the fall in elderly people. Another is walking while talking on cell phones, so attention is diverted, or any activity where attention is diverted. So now to evaluate the high level balance function, it can be assessed by one leg stance and tandem gait. Functional assessment, it can be done by functional reach, TOG test. Fall risk factors. There are certain factors like age over 75 years, history of previous fall, locomotor disability, decline cognitive functions, equipment attachment, or bladder or bowel urgency. If two answers are yes, then they increase the risk of fall. Approach. As underreporting is very common, hence every elderly must be asked regarding the fall episodes in the yearly. Every year we should ask. If there is single fall, then balance and gait problems, it can be tested by TOG test. If there are multiple falls, then intrinsic, extrinsic, and situational factors, they should be meticulously sussed out. And efforts should be made to either eliminate or reduce them by targeted interventions. By clinical examinations, most of the intrinsic causes we can get, like CVS, arrhythmia, valvular heart disease, postural hypertension, we can diagnose. By CNS, strength and tone of muscles, especially of lower limbs, deformity, pain, limitation of in the range of motion, coordination, including cerebellar functions, we can get all these by clinical examinations. A Rombox test, it gives us information regarding basal postural control, proprioception, and vestibular system problems. Ophthalmic examination, it should be done wearing the usual lenses. Functional assessment, TOG test, it is very important. In this, an elderly person sitting on an armchair is asked to stand up, walk 10 feet, turn around, and come back, and again sit down on the chair. If one takes more than 10 seconds, it shows that there is the increased risk of the fall. On meta-analysis, it was shown that in 60 to 70 years, usually the average time is 9 seconds the people take. In 70 to 80 years, they take 10.2, and above 80, 12.7 seconds. High-level balance function. One leg stands. If a person is able to stand on one leg without support of anything, he is having his hands on his waist and is standing on one leg. If he can stand more than 10 seconds, so he doesn't have any intrinsic defect. And tandem gait, if he has the accurate tandem gait for 10 feet, again, he does not have any intrinsic deficit. Functional reach, it is the distance in inches which a standing person can reach or lean forward without stepping. If it is more than 6 inches, it is less than 6 inches, it shows the increased risk. Weakness of the proximal muscles of the lower extremity, we can determine by asking the person to stand from a chair and then sit down 5 times without the support of the arms. If he takes more than 11 seconds, again it shows the weakness of the proximal muscles of the lower extremity. Balance, we can test by Rombox test or single limb stance test. The non-modifiable risk factors, like age older than 80 years, arthritis, cognitive impairment or dementia, female sex, history of CVA or TIA, history of falls, history of fracture, recently discharged from the hospital within 1 month. But the potentially modifiable risk factors, they are really very important. Environmental hazards, we should remove them. Medications, especially psychoactive, polypharmacy, if a person is taking more than 4 drugs, so we should try to either to cut them or to reduce their dose with the minimum possible doses. Metabolic factors like dehydration, diabetes, low body mass index or vitamin D deficiency, we should correct it. Musculoskeletal factors like balance impairment, foot problems, gait impairment, impaired activity of daily living, low extremity muscle weakness, and musculoskeletal pain and use of assistive devices, we can modulate them. Neuropsychology factors like delirium, depression, dizziness or vertigo, fear of falling, Parkinson's disease, peripheral neuropathy, and sensory impairment like auditory, multifocal lens use, visual impairments. Others like acute illness, alcohol intoxication, anemia, cardiac arrhythmias, inappropriate footwear, obstructive sleep apnea, orthostatic hypotension, and urinary incontinence. So now to management. Our aim of the management is either prevent or reduce the number of future falls and fall-related injuries and their complications. Every effort should be made to either eliminate or minimize potentially modifiable risk factors by individualized risk assessment. The multifactorial interventions are better than single intervention, and they include exercise, modification of the home environment, minimization of the medication, psychoactive medications, management of the postural hypotension, and management of the foot problems and footwear. If there is single fall and negative TUG test, then he should be prescribed with the general information about how to reduce risk of fall, like how to use drugs safely and how to reduce environmental hazards. If there are more than one fall and positive TUG test, then exercise program should be advised. The most effective exercise program is that which is tailored to the patient's deficit, given by a trained personnel, having sufficient balance challenge component and provided over long term, that is more than 4 months. Fall risk reduced by strength training, balance training, endurance training, and flexibility improving exercises. So the exercise really it is the most effective tool. Study have shown that it reduces fall by 30%. Recommended activity, Tai Chi for balance and coordinations, walking programs for the cardiovascular health, water aerobics for low impact strength building, and chair stand and balance for the leg strength. The medical management. If the drugs responsible for the fall are there, then either we should stop or reduce to the minimal possible doses. If disorders are there, then the proper treatment should be done. Like if arthritis is there, we should give pain management, physical therapy, and joint replacement, complete treatment. And for the environmental management, every effort should be done to reduce environmental hazards. For it, home visit should be done, home assessment, and then individualized recommendations like removal of mats and rugs, installation of the stair railing, wall railing, and increase in the nighttime lighting should be done. Footwear, the ideal footwear is that which is of tight fitting, having flat sole, having some ankle support, and have non-skid midsoles. These are just the home safety medications like removing tripping hazards, installing safety measures like the grab bars, wall railings, stair rings, everything. And lighting should be improved. And any loose rugs or mats should be fixed. The persons having increased risk of falls should be properly taught and trained. If they fall and cannot get up, because it increases the risk of dehydration, abdominalis, etc. What they should be taught? They should be turned from supine to prone position, then get on all the 4 limbs. Then they should crawl to a strong support system, and they should try to get up with the support of that strong, strong thing. If there is no improvement, then assisted devices like cane, walker, or wheelchair should be provided to them with the help of the physical therapist or prosthetist. It is a cartoon flowchart showing the prevention of fall in community dwelling patients. Primary prevention, if there are no falls. Then they report difficulty with walking or balance. Only then, if yes, then multifactorial risk assessment and multifactorial intervention should be done. If it is not there, just they are normal, then consider anticipatory guidance like group exercise, Tai Chi, home-based exercises, vitamin D supplementation if its level is low, environmental modification if severely visually impaired, referral to the ophthalmologist, advice about appropriate footwear, and counseling about medications and high fall risk. The same thing, if for secondary prevention, one fall, if there is no one fall, then these things should be done. But if there is fall, then the multifactorial risk assessment multifactorial assessment and multifactorial intervention should be done in all the conditions. Some recommendations. A-level evidence is present for the community dwelling older persons at risk of falls should receive multifactorial assessment and interventions tailored to their need, and exercise, particularly balance, strength, and gait training, and the vitamin D supplementation if the level is less. Others are being. The best practices, the multi-component program. We have to combine minimum more than 2 best practices. These are individual risk assessment, regular strength and balance exercise, gait and assistive device training, medication review and management, management of the chronic conditions and severe, vision correction, education, home safety improvement, vitamin D supplementation, and high hip protectors for fracture preventions. And the 4 pearls are regular exercise, medication review, vision examination, and home safety evaluation. The same thing, it is again a flow chart of this. And now to conclude, a targeted history and physical examination covering potential home hazard, cognitive and visual impairment, functional limitations, medications, orthostatic hypotension, and gait and balance abnormalities can be used to identify risk factors for falls. Numerous interventions, single and multi-component, have been shown to decrease the risk of falls. A combination of interventions such as an exercise program, medication review, home assessment, and vitamin D supplementations are useful for prevention of falls in elderly. Thank you. Thank you very much for your patient listening and taking from the Latsia Varanasi.
Thank you, A.K. Singh sir, for your and with knowledgeful delivery. And now we are knowing something about the prevention of fall, what exercises should be done, Tai Chi or yoga and everything. And very importantly, some railings, as Sarah said, in where there are more elderly in house, you should put these railing. In hospital also, hospital bed railings are very important, often forget. Often in our toilets also, in hospital toilets also, we are putting these railings to prevent fall, so that they can easily hold it properly and chance of fall is decreased. One more human approach is in recent time, I saw 2 elderly patients, and with heavy having some issues. They don't know what is happening. It must not be that. We should be more human. Some new generation, these values should be introduced as said. At night I'm calling the relative that you always speak and we are in love. Response we are getting are don't disturb us and do whatever. Reservice, in some extent, I have seen several sons and daughters. They're posted in US. They're even coming and they're even leaving the job for betterment of the parents, and ultimately after 6 months, after the betterment, after the whole care is completed, then they're only so both things are there. But recent 2 incidents I faced, I feel sad about that the society is going gradually. We should be very human in this. Our approach should be very human. The hands they've cared you 30-40 years back, and now we are just throwing them, cutting them. I think it should be this kind of symposium saving must be there must be more and more, so that some human values should be inculcated to our mind, young that's all. Excellent lecture. And any question? Open to all. Open to questions.
People take the opportunities first.
Thank you, sir. Thank you, sir, for the valuable insights. I request Dr. Supriya to please give the token of appreciation to our respected chairpersons, Dr. Tanmay Ghatak, sir. I request Tanmay Ghatak, sir, to please come on the dais. Dr. Ajit Kumar, sir. Dr. Ritu Karoli, ma'am.
My special thanks to my friend Dr. Ritu Karoli, who has come all the way from RML Hospital in the midst of a very busy day because geriatrics is her field of interest. She's a very avid endocrinologist, physician, and geriatrician. Thank you, Dr. Ritu.
Thank you, sir. Thank you, ma'am.
Sir को दो टोकन ऑफ एप्लीकेशन सर को देगा डॉक्टर कौशल से दिलवा दो डॉक्टर किसिंग सर को उसके बाद नेक्स्ट बताइए तुम बोलो I request Dr. Kausar to please give a token of appreciation to Dr. A.K. Singh sir after his talk. Love, Supriya. दूसरों का मत देते जाओ सेम ही को मत दे दो सबको घर भी ले जाना है नहीं ये नहीं वो हो चुका कमला Thank you. Thank you. Thank you. Thank you, sir. Thank you, Dr. Kausar.
Thank you, ma'am. Now proceeding to our next session. I would like to call up upon this stage our chairpersons, Dr. Neeraj Verma, sir, Dr. Punita Lal, ma'am, Dr. Sanjay Dheeraj, sir, Dr. Amit Kesri, sir, Pani, ma'am, to come up upon this stage and join us for our second session. It's high time to understand this infant in the medicine family, geriatrics though young as a specialty, holds immense relevance today. I invite Dr. Kausar Usman, sir, officiating professor and head department of geriatric medicine, KGMU, to lead this important session along with esteemed faculty. Thank you, sir.
So we have among us Professor Kausar Usman, and he is a professor in the Department of Medicine in George's Medical University right now. He has more than 80 international and national research publications, and he has won many awards. Some among them is the Brian Chapman Scholarship from the Royal College of Physicians. Then he has the Dr. G.P. Oration Award and Dr. M.M. Mittal Oration Award, and the Presidential Oration Award in 2019 has gotten the Best Teacher Appreciation Award also. So he will enlighten us on the topic. It's high time to understand this infant in the medicine.
Thank you, Chairperson. Good afternoon to all of you. First, my sincere thanks to Dr. Prerna Kapoor for giving me this opportunity, and my heartiest congratulations to start this geriatric symposia, which is a neglected segment of the field of medicine, I can say. Much has been discussed about the importance of geriatric medicine. I'm just going to give an overview that how at the end of the presentation, you will realize that how much geriatric medicine is important. Globally, there are 1 billion elderly, and by 2050, there will be 2 billion. If you talk of the India, at least we have 10% of the population is elderly. By 2035, 15% population will be there. And by 2050, 20% of the population will be elderly, and they may supersede the pediatric population. Life expectancy increase, we know. What is our aim? Our aim is to maintain a balance between lifespan and healthy span. We don't want to have our end segment of the life with so many morbidities and poor quality of life. This is the aim of the geriatric medicine. Most common illnesses, Alzheimer and arthritis, 2A, 2C, cardiovascular disease and cancer, dementia and diabetes. This is the changing structure of the society. If you see more the elderly, lesser the percentage in the society. But now this traditional pyramid is going to change into the new aging pyramid. You will have more and more elderly people. What is aging? Why it is concerned? There are certain things which comes in with the aging. But remember, aging is not a disease, but results in the gradual decline in physical and cognitive abilities, loss of adaptive response to medical stress, emotional stress, any stress. The adaptive response becomes less. So there is a growing risk of age-related disease. But aging is not a disease. You can see there are many patients who are 100 years, 90, but they're enjoying a good quality of life. And there are many who are in the 50s and 60s, and there are so many comorbid illnesses. This is the normal aging. You may be a little hard of hearing, presbyocusis. You may have benign forgetfulness, decreased blood vessel compliance. There may be a little bit increase in the body fat percentage with the aging. So it's not a disease. Disease will be dementia, macular degeneration, tympanic sclerosis, basal cell carcinoma, hypertension, obesity. These are the diseases. Why elderly are considered as a special group? Because they have chronic diseases. They have multiple diseases. And that's why they're on the multiple drugs, which is called as polypharmacy. They're often social isolation, poverty. For our country, the elderly are 60 plus for developing countries. For developed countries, it is 65 plus, already mentioned by Professor Dhiman and others. Why they are a special group? Because, as I mentioned, there are chronic, multiple, and multifactorial illness, so they must be managed by the multifactorial intervention. As was highlighted, there must be nutritionists also, physiotherapists also, physician also, orthopedics, ophthalmologists, urologists, and so on. Iatrogenic diseases are common and often preventable. There are many elderly who suffer just because of our treatment, interventions, procedures. Function and quality of life are the important outcomes. Our aim is to maintain their functional capacity and quality of life. Social support is important, and patient preferences. We should always respect the preference of the patient. I have seen so many patients are elderly, and we provide so many dietary restrictions that is not required. What are the common challenges? Presence of disease elderly, malnutrition elderly, frailty, polypharmacy, dementia, and mental health. I'll discuss only few top points about all these, and these are important. Presentation in elderly is different. It is atypical presentation. There may be patient with serious diseases, no sign and symptom. We have seen there are so many patients of the myocardial infarction without chest pain, and the patient dies. Could be. Unusual sign and symptom that are unrelated. A patient of the pneumonia may present to you with the confusion. Or even the opposite, a patient of severe sepsis may land with the hypothermia rather than fever. So in the elderly, presentation is different. And why it is so? Because there are organs which are the weakest link. Brain, musculoskeletal system, urinary bladder, and heart. And that's why the presentation of elderly, like in the pediatrics, there are only two symptoms in the pediatrician. Either they cry or they refuse to feed, refuse to eat. Similarly, in the elderly, there are only 4 common symptoms which we see: confusion, fall, incontinence, syncope. But acute confusion may not be because of the brain lesion. Incontinence may not be because of urinary tract problem. Syncope may not be because of heart disease. So we have to see what is the underlying disease. That's why it's very important. There's a difference between when you are dealing with the adult patient and you are dealing with the elderly patient. in adult patient, your approach is disease-oriented. Fever, cough, breathlessness, etc. Patient is a case of pneumonia. Chest pain, sweating, breathlessness may be acute common event. But here in elderly, be problem-oriented. A patient may come to you with the confusion. There may be so many causes you have to see. Patient may come to you with the fall, as mentioned by Dr. A.K. Singh, that this fall may not be, it will be because of poor vision. It will be because of environmental factor. So problem-oriented approach is important in the elderly patients. Malnutrition is a challenge which we often ignore in our day-to-day practice, irrespective of the department and specialty. We all know is a physiology that till 70 years, our weight increases. As the age increases, adiposity, fat percentage increases, our weight increases, our BMR reduces. But after 70, there is a decline in the weight. But this weight loss is associated with the increased morbidity and mortality. Who are at risk? Remember, these 9 Ds are important. Those who are taking drugs, dysfunction, poor dentition, disease, dehydration, diarrhea, depression, dysphagia, so many causes are there for the malnutrition. And one should evaluate these causes. A patient may have a simply poor taste and he may not eat, that is dysgeusia. Dentition may be poor. There may be disease, drugs, which is causing the loss of appetite. So all these should be considered as a risk factor. And remember, 35 to 40% of the elderly don't have the daily energy requirement. I don't write supplements and vitamins, etc. But this is the segment of the patient, elderly, where I prefer often to give the vitamins and supplements and to give their deficiency corrected. Like there are many who are the protein malnourished. Protein deficiency is there. 2 out of 3 elderly person often skip a meal and they suffer from anorexia of aging. What is the impact of the untreated malnutrition? Prolonged hospital stay, again readmissions, anemia, infection, wound healing is delayed, post-operative care is delayed in all these malnourished patients. Decreased functional capacity, there is a high risk of fall, increased morbidity and mortality. How to know that such a person is suffering from the malnutrition? You may go for the weight, height, BMI, etc. Fat-free mass, so many criteria are there. But clinically, if an elderly is coming to you, even serum albumin is a good criteria, which is also related to the mortality also. But if a person who is having the significant weight loss of appetite, interest in the food, complaining of the tiredness, irritability, annoyance, and feeling often cold, they are the patient, they may be having undernutrition. But do we treat undernutrition? Only 2% of the patients are treated. Hardly 5% are referred to the nutritionist for the treatment. 64% of the elderly lose their weight during hospitalization. And we don't give the attention. But remember, 70% of the patient has shown improvement if they are given proper nutrition. I prefer my elderly patient to be a little bit overweight rather than normal or underweight, because if a young patient is admitted, hospitalized, he can recover very early, very fast. But if an elderly patient gets admitted, after the illness, he loses weight rapidly. So if they are a little bit overweight, they will become normal. So it's better to have a little bit overweight rather than. Next is frailty. Frailty is nothing but the decrease in the physiological. There is increased vulnerability to the stress because there is an age-related decline in the various systems, whether it is cardiac, renal, all system, physiological reserve diminishes. So they are very prone for any stress, whether it is physical stress, emotional stress, or whatever it is. This condition, frailty, it's important to know, because if you know that this patient is frail, your extra attention is required, and these patients are at the high risk of morbidity and mortality. For example, a patient